It is my pleasure to introduce our speakers for this morning. All three hold or have held top medical leadership positions for the three largest behavioral health managed care companies in the country, Cigna, Optum, and Magellan. All three started their careers as providers, and all three are here and participating in this conference because they believe provider-payer collaboration and communication are critical for the future. Today they will share their perspectives on trends that are coming down the line and how providers can provide better care while getting better payment. Our first speaker is Dr. Doug Nemecek. He is the Chief Medical Officer for Cigna Behavioral Health Division and is responsible for oversight of all clinical programs, including behavioral health, lifestyle management, coaching, and wellness programs. Within this role, he oversees quality improvement, clinical outcomes, patient safety, treatment compliance, and utilization management, in addition to many other things. Following Dr. Nemecek, Dr. Fatima Tahill, who is the Senior Medical Director of Magellan, Complete Care, Florida. She is a psychosomatic medical psychiatrist that works in an integrated way with medical specialists. She has oversight of all behavioral health clinical care and operations aspects of the nation's first integrated health plan for the seriously mentally ill. She also has background and expertise in the commercial and public sectors of managed care, health system service planning, research, and policy. Our last speaker, but certainly not least, is Dr. Murray Zucker. He most recently was the Senior Medical Director of New Product and Innovation for Optum. The innovation team at Optum explored new models of substance abuse disorder use and eating disorder treatment, as well as evaluated new technologies addressing prediction, early identification, engagement, diagnostics, treatment, and disease management. So on that note, let me introduce these experts with Dr. Nemecek.
Thanks, Jerry. It's great to be back here in Naples for the conference. For those of you who were here last year, I was part of a panel last year talking about managed care, and it's great to be back to follow up, to tell you sort of where Cigna has gone over the last year and where we kind of see managed care and reimbursement and all of these things headed as we look into the future. I think in addition to the fact that I'm from Minneapolis, so any reason to get down here when they got 8 inches of snow yesterday is a good thing. It's great to see you all again and be able to talk about how are we all going to partner and work together to take substance use disorder treatment into the future and make sure that we are, number one, getting our patients healthy and getting them sober and safe and back to their lives, and doing that in a way that all of us can stay in business and manage into the future. So for my part here today, I want to spend the next few minutes talking about a little bit about this. The first question is going to be, why are we even talking about this, right? What's changing and where is insurance and reimbursement headed? And to that extent, I'm going to talk a little bit, not just about substance use disorder treatment reimbursement, but where insurance is going in general, because as you're aware, we're a small piece of the total medical spend, and insurance plan designs and everything are really being built on the medical surgical side of things, and we need to understand what's happening there as those principles and those practices start to roll down towards behavioral health and what we're all doing. I'll spend some time talking specifically about what we're doing in behavioral health and with substance use disorder treatment facilities and reimbursement and where we're headed with this. The move to value-based payments, partnerships, all of those things. I want to give you some details about where Cigna's at today and where we're headed. And then just finish up talking about the future and kind of those, the North Star that's out there where we're all trying to head when we get to the other side of where we are today. So the first thing is, and we've heard this a lot this week, I think, which is substance use disorder is getting integrated into regular and the rest of the medical establishment and the medical environment out there. Started Sunday night when talking about the gentleman who was up here talking about is essentially a substance use disorder treatment home in Michigan that provided full spectrum of medical and behavioral care. And I'll acknowledge with many of you that's not what's available in lots of places. But more and more we're getting to where, how do we integrate this? How do we make this more a part of everyday care? How do we get more primary care physicians to pay attention to substance use disorders and behavioral health issues? And where are we going? One of the key reasons why primary care and the medical side is interested in substance use disorders and things is the fact that the desire and the need for treatment is growing, right? There's an increasing demand for treatment. There's more people trying to access care. And like you, we see problems with access places, right? There's limited providers some places. There's trouble getting treatment. Lots of people just don't seek treatment. Primary care is not screening people and referring them appropriately. They're being discharged from emergency rooms without any follow-up. All of those things continue to happen despite the fact that there's an opioid crisis and people, hundreds of people are dying every day because of their substance use disorder. The other thing that's contributed from an insurance perspective over the last couple of years, and we touched on this even last year a little bit, is some of the legislation, right? And this has been a good thing from the availability of insurance for our patients. So mental health parity that's been around now, going on 8 years as we continue to implement the final regulations, increased and made access more available. Visit limits went away, benefit limits disappeared, residential benefits and benefits for residential level of care became more ubiquitous across health plans. All good things for our patients. The Affordable Care Act, then for the last several years, really the main impact that we've seen at Cigna from that, from a behavioral health perspective, in addition to the insurance being available on the exchanges and some of the administrative pieces, was the ability for 18 to 25-year-olds to stay on their parents' insurance. So for companies like Cigna, where almost all of our coverage today is employer-based, while we slowly get into the exchanges and some of the other markets, having that population grow and that demographic that much more prevalent and present within our population at Cigna is driving increasing demand for services, increasing need for us to really make sure that our network is adequate and able to meet the demands of all of these people. The other thing that's changing is the delivery system and the healthcare insurance in general. And I think this is where we're seeing changes both from our clients, the employers who are asking us what we're doing to help manage healthcare, and they see unsustainable healthcare costs. And we hear that a lot, and there's a lot of discussion and buzz about that and how we have to manage the total cost as a society. But that's a huge issue for employers, and they're starting to ask for, across the board, medical, surgical, and now behavioral substance use disorders. What are we doing and how are we changing the game? How are we partnering with providers to find more efficient ways to deliver care? How are we looking at risk-sharing arrangements? How are we driving and paying people for value of the care and not just for another day of providing treatment? How are we measuring outcomes, right? What data do we have? How are we using technology? We had the discussion on telehealth and telepsychiatry yesterday. Every client that I talk to asks us, what are we doing? How are we embedding and getting telehealth and telepsychiatry into our network so that their employees and families can take advantage of that? And lastly, they're asking us to come up with novel ways to configure a network. I've had this conversation with several of you at roundtables and other places over the last couple days, but it's interesting, while mental health parity made out-of-network benefits more available to people, because if you have them on the medical side, you have to have them on the behavioral side. Great thing, right? Well, here we are a couple years later, and on the medical surgical side, the movement is all towards how do they limit the network? How do they create narrower networks or high-quality networks? Health plans now, most of the health plans that they're starting to be sold on the exchanges as they grow have no out-of-network benefits. Not for medical surgical, not for behavioral health or substance use disorders. Even starting to talk about health plans that don't offer out-of-area benefits. So if you live in Nashville, Tennessee, you have benefits to see a certain provider group and network in Nashville, Tennessee, and you can't go to Florida or California or Texas. There's no benefits to go out of state to get treatment. These are the health plans that they're devising as ways to try to show employers and show people that they can contain the cost and contain those premium costs. And that is going to impact us in the behavioral health and substance use disorder field as well, because we will lose those benefits, or our patients will lose those benefits as well. So what are we doing at Cigna to try to address this move towards value-based reimbursement and to assist our patients in finding the best treatment facilities for them? One of the things that we've done now over the last year is we've rolled out what we call our designated substance use treatment provider program. I've had a couple conversations again over the last couple of days about this. You'll notice I'm not calling it centers of excellence. A couple days ago, one of the speakers up here asked who thinks their facility is a center of excellence, and lots of us raised our hands and said, yep, we're a center of excellence. I would challenge us, and I challenge even us at Cigna, I don't know how to define a center of excellence today. I don't know what that means. I don't know how to measure it, how I can compare one facility to another facility to really know that this one's a center of excellence and this one may not be yet. So we are deliberately in our network not calling any facilities centers of excellence yet until we can get to the place where we are able to measure the outcomes, have the data, compare that data, make that transparent and share it back and forth with you as the treatment providers and understand what really defines a center of excellence. But we know people are looking for what's the best facility, where can I go for this or that, how do I find the right treatment for me? And so we have moved forward with what we call our designated treatment providers. And we're looking at various categories to measure this. We absolutely are looking at cost. So if you look at some of the things on the slide that we're looking at to identify these facilities, total cost of care in an episode of care is one of the factors we're looking at. But we're also trying to look at the quality as best we can with metrics that exist today. So that's looking at what services are being provided, how extensive and how much of the spectrum of care is a facility able to provide. So we're much more interested in talking with facilities that someone may actually travel to today who still has those benefits. What are they able to provide? And if they just do detox or just do residential, we're less interested than if they also have detox plus residential plus a partial hospital program and can truly individualize the treatment for each patient that may go there. We're paying attention to what additional services, what specialty services do you provide. We're looking for high volume facilities as well. So we want to make sure we truly understand and have enough data to be able to say, yes, we know how you are treating our patients. We know what in general outcomes look like and what we think they're like. So how can we drive more business to some of these facilities to continue to do that as we continue to evolve and grow our ability to measure outcomes and do that better and more transparently. We're looking at this from a relative value perspective. We're measuring things the same way they measure and display facilities for medical surgical care. So at Cigna's taken a STAR approach to telling you which orthopedic surgeons are the designated or high quality orthopedic surgeons. If you're going somewhere for cancer care, they've got 3 stars and you can find the best cancer treatment facility. So we've adopted the STAR approach at Cigna to do it in a similar fashion on the substance use disorder side and behavioral health side. You get up to 3 stars for quality of care. that looks at readmission rates and ambulatory follow-up rates and those sorts of things that are available today. And you get up to 3 stars from a total cost of care perspective. And if you can get 5 or 6 stars on that sort of thing, we will consider you for possibly this designation in our network. We're going to share those metrics with you. Obviously, make sure that that's fully transparent. That's why we need to have metrics that we can see, and we're interested in working with these facilities and continuing to develop and identify what are the ultimate outcome metrics going to look like. So our customers ultimately are going to be able to call us at Cigna and ask us, I'm looking for this kind of facility, high quality facility, I need this program or that specialty program, I'm really interested in making sure they focus on my wellness. I'm interested in the extended family program because my family really wants to engage with me in treatment, whatever it might be. We're going to know what your facility provides, what special services, do you have special tracks for law enforcement or professionals or whatever it might be, and really be able to try to help our customers understand they can get those programs and that stuff in our network. They don't have to go out of network. They don't have to maybe travel as far, and their cost is going to be lower if they stay in network. Again, that's important to our clients and to the customers in this era where deductibles are going up, out-of-pocket maximums are going up, and customers are starting to pay attention to that cost of care. And our clients, again, are asking us for this so that they know and they can be sure that the patients that are taking advantage of the insurance that their employer is paying for are getting that value. We're collaborating with physician groups from an integration perspective too. So this is another area where we're focusing on how do we work better with primary care and medical care to make sure that they're paying attention to substance use disorders. So think accountable care organizations. How many people have heard of accountable care? I'm sure lots of hands, right? So we're looking at these accountable care organizations. Cigna has about 140 to 150 of them around the country now, about 1.5 to 1.75 million members for Cigna who are participating in these accountable care organizations on the medical side, and about 65,000 physicians, medical and specialists who participate in these. So, for a company the size of Cigna, we're getting beyond the 10% of Cigna membership and things that are participating in these accountable care organizations. And we're looking at now, as they try to control total medical costs and are getting paid bonuses for controlling medical costs and improving quality, they're interested in recognizing the fact that the people who aren't getting better have substance use disorder problems or have another behavioral health issue, and they want our help in addressing that. So we're working hard this year to figure out what's the best model, how do we embed behaviorists into these accountable care organizations, how do we help them screen, how do we wrap networks and partner networks with them so that they can provide that care, have referral options, have access, and make sure that people are getting the follow-up care, the assessments, and the treatment that they need, and maintaining that communication back to the accountable care organization, the primary care doc or the specialist there that is ultimately responsible for the patient's total care. So a lot of work going on there. And then lastly is our pay for performance. We've got 7 facilities that we went live in November with this, where we're measuring outcomes. We're looking at measurements, again, from an outcome standpoint, and we are looking at this point from a financial incentive perspective, just on annual rate increases until we can get enough data, find the right outcome metrics to get to a point where we're able to start paying quality bonuses and things like they do on the medical side. But we're trying to get there. Our goal is to have 80 facilities doing this with us over the next 4 years, so we're growing rapidly. And really working to try to find what are those outcome metrics, how do we find some standards, how do we start to use those across the network, across the country to really compare facilities and start moving to a point where we're paying you for the outcome and not just for providing another day of care. So as I'll close here, just some thoughts about the future. This is where we're going. Obviously, it's all about the triple aim. We want patients to have better outcomes. We want better cost and better affordability for those outcomes, and we want a better experience for the customer as they go through the healthcare system with all of us. We need to work together to get there. Insurance, providers, all of us need to make sure that we get the system put together the way that it helps and takes care of our patients so they're getting what they need. And we want to do that together. That's why I'm here. That's why we're all here today, to help carry on that conversation. It was scary. I saw an Accenture study recently. They talked to 100 healthcare CEOs, asked them what healthcare was going to look like in 10 years. They talked about some of the typical things: genomics, technology, telehealth, things like that. But they also said some things that probably are a little scary for all of us, like they expect maybe only 1 or 2 health systems in every major market, maybe only 100 health systems across the United States left after consolidation and everything else. They talked about the fact that health plans and provider groups, as we know them today, may not exist. There'll be hybrids and different organizations that haven't even been named yet that are driving healthcare, and that these new health systems will be responsible for populations of people. I don't know if we're going to get there in the next 10 years, but that's the direction everything continues to move, and we're going to see where we all land, and we need to help shape this to make sure that substance use disorders don't get lost in the shuffle, and make sure our patients continue to get what they need. So thank you.
So this morning what I want to do is actually talk to you with regards to what you can do as the trends are changing with regards to where substance use is in terms of the whole healthcare landscape. I think Dr. Nemecek here did a wonderful job in terms of laying out how the landscape is looking at this point and where we need to go somewhere down in the future as the trends move in a very different direction of how we're traditionally used to. So what I'd like to do today is just talk to you a little bit about current state, but bring it down to the level of the provider and see what you can do in terms of transforming yourself. We've heard a lot in terms of where things are going with regards to product innovation. My perspective is there needs to be provider innovation, and what that means is that needs to be changes down on the provider level so that you can be in step with the changes that are occurring on a much larger landscape. So what I'm going to do is just start off and talk to you a little bit about the fact of how the current landscape is actually structured. Many of you know how it is because you're participating in that structure in and of itself at this point and what that infrastructure looks like. We know for the most part that both the physical health side, and I will talk to you about both the physical health side as well as the behavioral health side, because for the most part we know that services to our members and our patients have been very separated and totally disintegrated. There have been separate systems of care, and we know for the most part there have been silos. And silos are not only existent between the physical health side, but also on the behavioral health side. But if we look in as far as the behavioral health side, and by that I mean behavioral health side with regards to mental health services and substance use services. And if we look within that, we know that these two systems have never really spoken to each other much. And if I look at all of you today and ask you, with the services that you provide, where does the behavioral health piece actually come in? And in fact, where does the physical health come in? And the answer would be very different depending on where your organization is or where your facility is with regards to the move towards that trend of integration. So my focus today really is to talk about integrated delivery systems. So as I said, we know for the most part in terms of comorbidity or co-occurring disease that you will not find one person who just has a physical health illness. Most of them will be complicated by behavioral health issues, and when we talk about this, we're talking about mental health issues, depression, anxiety, and for the most part, many of them also suffer from physical health issues. It is not uncommon for someone to also have diabetes, hypertension, COPD, and a whole slew of other medical conditions that coexist with someone who has substance use issues and struggling with addiction issues. And we know as a fact that the trifecta of all these three things, physical problems, mental health problems, and substance use issues makes it very, very hard to treat one member because the systems at this point in time are so separate and not integrated at any point. We also know in terms of healthcare costs that the cost for care for someone with all these three conditions are very, very high. If you think about someone, or if we look at studies have shown that 15% of one person with these three different comorbidities, in fact, can account for 30% of total healthcare costs. So that means they're consuming a whole lot more of resources. And we look at that in terms of a health plan and in terms of payer costs, we know that this is exorbitant and we need to control that. So if we look at this, as the slide shows you here, the 2014 data that shows that 40% of adults with substance use also have a co-occurring mental health disorder as well. And in fact, as I said to you, if you look into your programs today and figure out how many of you actually have a physical health physician, that would be an internist, family practitioner in your program to provide these services, that would be a very, very small portion. It looks like, only 1 in 2 addiction programs have no physician. And so moving on, with regards to the regulatory landscape, you heard a lot of talk about the changes in the landscape wherein we're looking at parity in terms of open services, more access to care, and all of this is just really pointing to research where we know that better care actually improves lives. And when we improve lives, we promote recovery. And when we look at that as well, and in controlling population health management, we know that services and costs can in fact go down as well. So the focus right now in terms of the landscape at this point really looks towards pushing for value. You've heard this early on, talking about value. So here at Magellan, we talk about value-based purchasing. So that's something that we're looking at in our networks as well. But aside from that, we know that for the most part, for you to survive, it's really, really important to show the ability of quality metrics, quality outcomes for the members that you treat. And again, here we talk about a triple aim, which talks to patient satisfaction with the services that you actually provide. We talked about improved outcomes being in terms of healthcare outcomes, and also in terms of costs as well. Okay, so here, the question is really, so with the systemic fragmentation of healthcare delivery at this point, is really integrated care the answer to it? And the answer is probably yes. And is it really good for you, or is it really good for the patients? From a patient perspective, we know that access to care has been limited for many instances, and limited not only in terms of what's available to them, but also in terms of the comprehensive services that require. How are they going to get integrated care where they can actually, in treatment with you, get mental health services and get physical health services as well? So that's really important. But we also know that integrated care at this point in time is really good for the system as well. System being the overall healthcare delivery system. So why is this not part of the solution at this point? I think the answer is there are a lot of barriers, and some of the barriers I'm just going to talk to you about as well and provide to you some questions that you probably can ponder on in terms of the services that you guys are actually delivering at this point. So is there evidence for integrated care? Yes, there is. There's been tons and tons of studies out there to talk to integrated care in terms of how it can improve clinical outcomes for your members and costs as well. We also know that integrated care will really open the door in as far as providing access to services and also providing referrals that many of the members need, not only for physical health, but also for mental health services once they're done with the services that you provide. And of course, we know for the most part that recovery from substance use is really, really key. And this is something that you can actually use as part of that you can use in terms of promoting the services that you are in terms of marketing. So if here we look at in terms of abstinence, we know that abstinence can actually be improved once substance use patients and members that you have actually have access to primary care services. So we know, for the most part, the evidence is there. The question is, how do you actually get there? How do you get to an integrated care system? So what is the roadmap? So as I said earlier on, part in the beginning is product innovation have been the key in the past few years or so, have been involved in that as well, and looking at, what sort of products can we actually create to innovate, to be different. So how do you get to be different provider in the playing field here? So my suggestions here is what we do is we need to look at what sort of unmet needs are available. And if these needs that you identify out there, whether it be in terms of clinical services or in terms of a population cohort, that's going to be really important. You need to go back and look at the services that you provide and figure out, well, are the services that I'm providing, the clinical services that I'm providing, are those services actually something that is needed? Is that something that I can improve over time? Is that something that I would have to pull back and revamp in a different fashion? Those are things that you need to start thinking about. If we think about services that you have, whether it be in the residential level of care, PHP or IOP, how are you going to be different from your competitor? How can you decide which services you have there that you can actually focus on and hone in to make it different? So some of these things I'm going to talk to you about. And then if you find out that there are certain unmet needs that are in your community or outside, what are these needs? What can you do? Are there services that you need to think about developing so that you might target a specific group of people? Are there certain services that you need to buttress? What are the things that you actually need to do to actually be totally attractive to a health plan? What can you do to be different? These are the things that you really need to take an inside look first. And then from there, what you need to do is then look at it not only from the clinical perspective in terms of services that you provide, but how is that going to affect you in terms of operationalizing it, and also how is that going to impact you in terms of the financial bottom line as well. So one of the things here, not too different from the field of medicine, you need to decide whether you need to specialize and be a specialist as in a cardiologist, or do you need to be a generalist wherein you're providing services specific to a general population, like a family practitioner, where you can treat one and all. So these are things that you need to think about. And when we think about substance use services, we know about addiction psychiatrists, addiction specialists, but also need to think a little bit beyond that realm as well. What are you providing in your service system that you could use and sell as a marketing point that will make you a little bit more, if not much more attractive to health plans? How do you differentiate yourself here? In as far as evidence-based treatments, what is new out there? What can you use different? What about medication-assisted treatment? Are you using this to the extent possible? To what extent, with regards to medication-assisted treatment, are there outcomes that you can show, that you can share, so that, again, you're different and you can market yourself in a much better way? And we talk about populations. So populations, they're a huge... There's different ways of looking at special populations, and I talk about pregnant women, I talk about child and adolescents, talk about the SMI population, the seriously mentally ill. All of these three different populations have very different needs. If you are able to focus on services specific to them and go to a health plan and say, hey, I've got a plan that's specific to pregnant women, how are you going to handle this? How do you actually create a plan for pregnant women wherein you're dealing with their needs throughout their pregnancy and making sure that if they do have a co-occurring mental health problem like bipolar, that you're also treating them while also treating their addiction to opioids. So these are things that you really need to look into and figure out, well, is this a population that I need? Is there an unmet need in the community that I can actually fill and create services for? And then, of course, you also heard that there is this huge movement towards population management, which is part and parcel of the whole reform of how healthcare landscape is moving forward, too. So we need to make sure that as you're not only treating the patient on an individual basis, you need to pull back and look at the forest instead of the trees. And that's where you can also sell some of the services. So these are kind of like things that you need to start thinking about on the level that you are, because these are things that are going to make you very different in terms of your competitors and make yourself, much more marketable. So if we look at different change concepts, and these are concepts that I just want to bring up to you so that it's not something that you've never heard of, but I think it's important to just also bring up and pull it to the forefront. So we talked about barriers of care. Barriers of care have been in existence for a long, long period of time. How can you actually improve access to care? Can you improve access by providing services to pregnant women, say? Can you provide and open services to the seriously mentally ill, a group that's totally challenged in terms of what they have in terms of co-occurring disease, and a group that, in fact, has a lot of a high readmission rate and high substance use as well? What can you do in terms of care coordination? Care coordination is so important in terms of transitions of care, and this is what CMS is looking for in terms of making sure you're able to coordinate care between providers. When that member leaves your facility, where do they go? Can you provide that transition of care back into the mental health system? How do you ensure that these services are intact so that that member does not come back? Because we want to make sure that the member that you're seeing is not going to have a readmission within 7 days or within even 30 days. So these are some of the metrics that we're looking at that you also heard Dr. Nemecek talk to you about. If we talk about changing delivery of care, we talked about evidence-based medicine. What kind of services do you need to pull in? What sort of clinical practice guidelines do you need to follow to show that you're different, that you are in fact, at the top of the line in terms of service delivery? And in fact, what do you do to ensure that there is patient engagement? Patient engagement is something that is very new, something that we've never thought about before, but more and more we want to make sure that the patient is not only engaged in care with us, but we can make sure as part of coordination of care, there is engagement with the next provider. What does that mean? That means you need to create partnerships with the providers, whether they be on a lateral line or a vertical or a horizontal sort of partnership that you deal with other people as well. And of course, I got 5 minutes, talking too much here. Okay, so building relationships, I think that is really key. We, as I said before, the whole thought of being in silos, we have never established partnerships with each other, but it would be key for you to start thinking about building partnerships to sort of like fill any gaps that you don't have at this point in time. If we look at the behavioral health system, we know that many of our behavioral health providers are not in sync with the others. Why? Because they have been working in silos for the longest time. But if you think about grouping them together, there is a lot more power in larger numbers in terms of volumes. You're able to actually be able to, now I'm losing the word, be able to actually sell yourself as a much stronger plan as well. And as we move forward as well in terms of looking at that as well, what can you do to engage your leadership? What can your leadership actually do outside of your organization to actually partner, to foster any kind of collaborative initiatives as well, not only within the substance use community or the addiction community, but also what can you do to connect with the health plans? What can you say to them? Can you get them engaged? Can you partner with them? Can you sit with them and say, hey, I have an innovation here. We have this product that I think would be really great and in sync with your health plan. Can we work together? Can we work together even in not a clinical sense, but can I partner with you? Can I sit on your stakeholders advisory board and have that kind of connection actually built up? And of course, the biggest thing is, and I don't know where in terms of big data, in terms of data collection you guys are, but in terms of outcome metrics, it is so key for you to actually look back in terms of the treatment outcomes that you have and use that as leverage for any conversations that you have with the health plans as well. And last but not least, again, looking at technology and seeing where you are with regards to any sort of electronic health records. Can you actually use those health records to actually integrate with the next system, coordinate care through those systems, and then, of course, telemedicine. We can't not talk about telemedicine because it looks to opening access to members as well for services, whether they be specialty services that might be needed in terms of physical medicine or otherwise. Okay, and at that, I would just stop there and just ask you to just actually really go back, look at what you're currently providing within the system of care that you have, figure out what sort of steps you need to take to identify the unmet needs that are out there, and go outside of that box of comfort that you're in, and start looking at your partners in the community, establish those lines of communication so that you can partner with them, whether they be, an addiction facility, a mental health facility, or a primary care provider, because being able to integrate all those three services together makes you so much of a provider that a health plan would be very much interested in partnering with you, because again, the bottom line is making sure that the member that we're treating, the patient that you're treating, is really going to have significant health outcomes that's going to impact not one, but all. Thank you.
Well, I have the distinct advantage of being last and the final talk here at the session, and the advantage is to be able to summarize my entire presentation I agree with everything that's being said, so thank you. Because really, many of the things that you've heard throughout the past few days will be re-summarized here in some of the things that I'll be saying. But I thought that in order to end the session here with a to-do list, because there's been a lot of things going on here, a lot of interesting suggestions, a lot of dynamics, a lot of feelings, a lot of intensity. And perhaps one of the things that I can do is have you be able to take home a to-do list for some of those of you who are providing the care itself for the patients. And I thought as I went through the past few days, one of the things that occurred to me that they probably should have played some theme music as we went from session to session, and it would have been Bob Dylan's "The Times They Are A-Changing," because that certainly is true, and with changing times comes increased anxiety. With changing times and the anxiety comes opportunity or a chance for regression, as we know. So in preparing this, I thought, God, I'm kind of feeling like I have a few different roles and hats, and that in some ways I'm a consultant. That's what I do. I'll be consulting, giving some recommendations. And in some ways, I felt that maybe some of this talk was as an industry executive, having been there and done that and created these systems and helped execute them. And in other ways, in preparing this talk, feeling like a little bit of a therapist, like, okay, so everybody's anxious, times are changing, and here's a dose of reality and some therapeutic exercises. So sort of encompass it all. And just wanted to state something as a disclaimer here, that I had been with Optum for a number of years as senior medical director, and continue to consult with Optum on a part-time basis and do healthcare consulting. So just for the record, my comments are not representing Optum per se. So I thought that maybe one of the things too is to consider changing the title a little bit of the talk from increased payment. I'm trying to get the slide to change here. There we go. From increased payment to really just how to position yourself and be part of the team of healthcare delivery that's really going to move ahead and be one of the participants in some things that are changes anxiety-provoking, but it's also very challenging and very exciting. So really a call for positive action. And to start off, I'm going to name drop a little bit. 2 weeks ago, I had the good fortune of having breakfast with Patrick Kennedy. And who was just terrific, and it was a wonderful breakfast. And I was thanking him for his work on Parity, and he said, you know, yes, I'm proud of that and all the work that a lot of people did. He said, now I've come to realize that Parity is just the first step, and Parity is not everything. Access is nice and it's important, but really now I realize what's important is outcomes and quality. And that had a profound effect on me, because we've all been looking at that and feel that way. And to hear a visionary and a leader in the field say that, I think had a great impact. So I just want to have you keep that in mind as we go through and take a look at things. So the present situation, as you're hearing from all different perspectives up here, is a good news, bad news story. And it depends what you do and what you make of it, and generally it's a bright future for those who get on the train. So one thing on the good news side is demand is going up, and we've heard all different reasons why and how that happens. More expansion of coverage with Parity and Affordable Care Act and all. And then not so good news, and kind of very sad and tragic, is the opioid epidemic has made substance use front and center in the society, politics, healthcare, and in health plans. We're all thinking about, you know, how in the world do we all get together and deal with this? But on the positive side is certainly enhanced awareness. So your issue is front and center, as you've heard from many people and as you well know. And the other thing, too, that's a good news story is that there's much greater recognition and awareness of what you do. That in providing care for substance abuse and mental health, people are realizing now that this is very important to the entire healthcare system, to integrate care. And then, you know, in terms of cost effectiveness, people know that really if you don't treat the mental health comorbidities, substance abuse comorbidities, the cost of healthcare skyrockets. So let's look at a few ways that this happens. You know, sometimes when I'm giving a talk to medical organizations, hospitals, and the like, I start off a slide before I really get into the talk with a slide of a pill resting in somebody's hand, and I say, before I start my talk, I just want to see how many people want to invest in something that I've come up with. I've got this thing that will reduce healthcare costs maybe 10, 15%. It's a sure thing. Anybody want to invest in it? And everybody, of course, raised their hand, joking around. And then I say, well, it's not a pill. It's really medical behavioral integration and treating, you know, comorbid substance abuse in the medical setting. So this is really one of the last great changes in medicine. You know, there are new pills that, you know, improve things a little bit here and there. New treatments and new devices, which are very exciting. But none of them really can have an impact of potentially 10 to 15% of the total medical care cost that mental health and substance use treatment can. So you have in your hands and in your skill set and your experience the ability to affect the medical system like nobody else. No new devices, no new medications. And the challenge really is how to harness that, how to integrate so that it can be felt and that can be actualized. So, you know, we've heard also here that it's really wonderful that now substance use mental health has a place at the table with medical care. And with that comes new rules. And like we heard yesterday, we have to get used to those new rules. And it's a lot of responsibility. And now we're around the table with the big boys and the grown-ups. But you have to be careful what you ask for. So now that, not sure where to point this. There. So now that we're at the table, be careful what you ask for, because in a way, first of all, you're a new guy at the table, so there's a little bit of, well, who are you, and prove your worth. And also, we come to the table and we look, God, we got a little mud on the carpet walking in because of reputation and some of the things that have been going on out there. And unfair, fair, it's not the issue. The point is that now that we're sitting at the table with the healthcare system, you really have to prove your worth and really have to clean house in your own industry to be credible and professional. So, it's important to understand that what you do is very valuable, very needed. So you do have value, and approaching your place at the table in the healthcare system with a lot of confidence and self-respect. So where else is the demand going? There's more opportunity than ever, really. We're talking about all these cutbacks and severity and cost effectiveness and what are the payers thinking. But if you look at it from another perspective, and the opportunity is bigger than ever. There's more patients, so we talked about why. There's more of a role for what you do and an appreciation because of medical cost offset and the potential of medical behavioral integration. And bottom line, you can have, with more people that you have access to, you can make a much greater impact on people's lives. So it's actually a very exciting and challenging environment. However, with that, and there's some challenges, there's going to be winners and losers, and we'll go to the next slide. And I think everybody here wants to be on the side of the winners, and so there's some things to do to be on the side of the winner. So let's take a look at a few things, and can we hit the next slide? There we go. So let's take a look at some of the current trends. Now, you've heard these things in many of the talks, and they've been reviewed in the talks preceding mine, but just to mention again, the triple aim and the patient experience, we keep hearing that, and that is crucial because we tend to forget what it's like for the patients encounter when they call the insurance company. What is that really like for them? The confusion and stuff that they may encounter. What's it like to try to figure out which treatment program to go to and all the ads on TV and glossy ads and horseback riding and surfing and things like that? What does that have to do with substance abuse treatment? So it's very difficult to be a consumer in a state of crisis. Who do you turn to? What's credible? And you could say, well, consumer beware, but we're talking about healthcare. It's not exactly like buying a new car. So we're also interested in better outcomes, and you've heard a lot about the importance of outcome studies. And nothing is simple. I mean, if anything is valuable, it's not simple. And we're finding in the current political situation that simple answers really defy logic and reality and really not going to help us as a society. So things are complicated, and that doesn't mean that we should walk away. That's just really more of a challenge. Cost effective. The reality is everybody, says, well, more is better, at least from sometimes from a provider side. Well, more isn't necessarily better. What we really need is effectiveness, both effective outcomes and cost effectiveness. As a society, we really can't afford such runaway expense and to treat everybody with everything without knowing what the result is and whether there's going to be an outcome that's associated with it. So in the environment, again, just to review what you've heard before, there's a consolidation of payers, and you're reading about that every day. There's a consolidation of providers. Private equity has gone into the field of eating disorders and substance use treatment, and that's going to have implications in terms of what they do with that aggregation. Are there going to be efficiencies, standardization, uniformity, emphasis on outcomes? Or are things going to stay the same with even more intense advertising? And again, it's up to each group to decide how they're going to position themselves. But again, in this environment, there's tremendous opportunities. So we talked about outcomes and accountability, digital innovation, and we'll get into more detail about that. And also new formats of delivery. I mean, number one, there's going to be new medications coming down the line. Number two, new treatment approaches that will be validated and hopefully more effective. And new payer arrangements, as we heard before. Now, all of this newness is pretty nice unless you're in the middle of it and you've got a model that's working, and now you have to adjust to what's uncertain about the future. And this raises anxiety because it raises risk. With risk, there is potential reward, but that doesn't mean that the risk is without its anxiety. So psychodynamically speaking, it's interesting to watch how organizations and provider groups respond to the anxiety that's associated with the change and the risk. So, one way is denial, and that's pretty easy. One other way, even more fun, is regression. You have a temper tantrum, and play the role of the victim and blame everybody else. So that's kind of fun, but not very adaptive, and it's certainly not something that we as therapists and you as treating people with these severe problems, you never advise denial or regression, I'm sure. So, and another thing I'm sure you don't deny is use some substance just to numb yourself for the realities, and I don't advise anybody does that. So on the other hand, though, to rise to the occasion, and so how do you deal with anxiety? You focus, you have your goals clear, you get consultation, and then you try. And if you're afraid of failing, well, then there's therapy for that. But it's okay to try things that don't work. It's okay to make a pitch to payers and feel that it wasn't understood, and then revise your pitch and come back again. So really, in the face of risk and challenge, the name of the game is to really try new things, find out who you are, turn inside, turn to your organization, define where you want to be and what you're good at, and then go in that direction. So the challenges are all there, and again, you've heard it all. There's increasing emphasis on evidence-based practice, and some of the talks were very good in pointing out that's not so simple either. We use that term a lot, but it's a lot of complexity there. But it doesn't mean you should shy away from the literature, keeping up your education, and going to conferences, like this to be sure you're getting sort of cutting-edge information. Everybody's heard of MAT, medication-assisted treatment, and I just wanted to say it's kind of interesting observing, some people's reaction to that was like, oh, that's a new religion, or that's a philosophy, or whatever. But it is a reality with clinical trials. Now, it's not an exact science, and there's got to be a lot more research in a lot more areas, and there'll be new medications. It's not to say that medication is the solution to everything. That may be an error that some people are making in assuming, but it's part of the armamentarium in approaching this problem. But in your approach to the change is really to consider integrating that into your program. So the other thing we're all faced with is the systemization and professionalization of what's going on. We had an industry that did a lot of good work, a lot of dedicated people, and now there's a new demand for accountability. Now there's a place at the table in healthcare. Well, along with that place at the table with the big boys is regulation, payer involvement. And that's not necessarily comfortable, but it is kind of exciting and a new skill set to learn, and you have a lot to offer, as I mentioned before. One of the biggest things, of course, in this whole equation is the cost pressures that everybody is sensing. So as providers, you're sensing things about, reimbursement rates might be going down, lengths of stay going down, utilization changing, increasing pressures towards more outpatient treatment than structured facility-based, and all of that. And it's real easy, again, to react in denial or to regress and blame everybody else. But this didn't happen in a vacuum. I mean, the fact is that we can't afford to pay, I don't know, how many people here want to pay 150% of their income in taxes? I don't see any hands. So it's not sustainable. I mean, it's just not, we're grown up, so we have to be real about this. We can't afford to give everything to everybody just because they want it. So we have to really be mature about it and see what works, what's cost effective, are there better ways to do things. So the whole system, the employers, they have to watch their budget. The individuals, the workers, the citizens of our country. We can't just spend everything in our wallet and then not have anything for a rainy day. And insurers managing the benefit and making sure that healthcare is sustainable. So we're all in this together, but everybody's under the pressure of cost. So if in your treatments you find a way that's more cost effective, then you really should approach the payers and say, this is how we're doing it, and this is our outcome, and it's cost effective, and then everybody wins. The other thing, too, that's a factor, and you've heard from everybody, is technology. And that's got a place, because if we have to be more cost effective, if our outcomes have to be better, one of the ways to help do that is through technology, and you've heard a lot about that. But the technology has to take into mind the consumer experience, some of the payer requirements, and of course the clinical effectiveness. So we've got, as I said, an enormous opportunity. There's more patients available. Your services are key and needed. You can affect the whole, spending curve in medical industry. And I broke it down in some suggestions into 3 areas: clinical, operational, and financial. So let's look at some of the clinical. We mentioned evidence-based. I mean, that's the ticket of admission. So if you're going to be at the table, you really have to look at the evidence, and you have to be practicing according to that. You have to understand that things are now with a lot of medical oversight and based on medical necessity. And I've heard at some of the talks, people were bashing the payers and the insurance companies about some of their practices. But, it's not, some of this stuff is not that difficult. I mean, medical necessity, all the requirements are published. You have access to them online. The other thing you need to know is that most of the insurance companies, really, they're pretty much the same. It's not like anybody, has their own qualifications that are so different from everybody else. And then in part of the medical necessity, they also have, requirements of service delivery. And they're not made up to be arbitrary or punitive. They're just based on research, best practice, and protecting the consumer. So for an RTC level of care, if the medical necessity and treatment guidelines say for residential you need 24/7 nursing care, that's not to run you out of business. That's to protect the patients, because if they're really getting residential care in a semi-acute setting, they're just coming through detox. Their brain and body is suffering from not withdrawal per se necessarily, but really the changes that go with early abstinence. And you really do need a psychiatrist or a physician availability every day. You really should see a psychiatrist once a week in that setting, and you really should have availability of nursing. So it's not arbitrary. It's really something to get on board with. So that's something to consider in your facilities, to take a look at the medical necessity criteria and then match your program so that you fulfill those criteria. All right, so individualized care, individualized consumer-based and precision medicine based on clear pathways. The days of trust me are over. You need to prove that you deliver value and quality. That leads to outcome focus. The next thing, with data, transparency, and sophistication. And I realized as I heard a lot of these talks that those phrases are important and easy to say, and then people scratching their heads who may not be familiar with, well, how do you really do this? And what are the steps? And we'll go through sort of the to-do list at the end of the talk. Essentially, you need to start with an EMR. You need to get consultation. You need to hire a healthcare data analyst. And you need to be thinking about what the industry needs and also how to tell your story using data. The other thing we've heard a lot about is taking a look at, now that we're at the table with medicine and the healthcare system, that really we're dealing with a chronic disease. So we have to stop looking at, we treated you, goodbye, have a good life, and don't come back for 30 days or you'll make my statistics look bad, but really responsible for the patient throughout their disease, and that means long-term, that means chronic, and to be figuring out ways of engagement with the patient, care management, and other strategies to keep somebody functioning and doing as well as they can with this chronic disease. So some other clinical implications: staff training is very important. Keep up to date with the latest interventions, motivational interviewing, DBT, CBT, as mentioned there, mindfulness, computer interactive strategies also to take a look at, and then engagement applications that you might have heard something about, but there's some evidence to show that that might actually improve long-term engagement, and it's also a great source of longer-term outcome data. The degree of your staff training and sophistication is the #1 variable the research shows that correlates with better outcomes. So in facilities that have a more stable staff, less turnover, their outcomes usually are better. In facilities that have full-time people as opposed to part-time FTEs, people coming in and out, those facilities tend to do better. Facilities that have higher degree training staff, those facilities, their outcomes tend to be better. So you might be thinking how to gear up for that. And then you also heard about specialty niches as something to think about. Adolescents, legal, impaired professionals, and pregnancy, and that's medically ill, not medially ill people, and that means integrating with the medical system. So I mentioned about the service requirements of the payer, the 24/7 nursing, psychiatric evaluation within 48 hours, and at least weekly psychiatric visits, and family therapy. In doing reviews for years, it amazed me how infrequent true family therapy happens in both the mental health side and substance abuse side. And this is a disease that affects the family, if not a family disease. And the family, if it's intact and supportive, is really a change agent. So how could family therapy not be an important part? And also be thinking about the least restrictive setting. So a lot of these concepts are things you really should be incorporating and keep in mind. We talked also about, individualized care, and I was impressed with one of the speakers yesterday, Dr. Hoffman, about really it's much more complicated than you think in looking at all the variables of risk and then adjusting your treatment plan specifically to that person's needs rather than the facility's needs. Because it's much easier to treat your own facility because it's cost effective for the facility to have a bunch of people in group therapy and all that, but that, which works for a lot of people, but it may not work for some people. So you really have to be able to evaluate each individual, assess their acuity, assess their needs, and match your treatment plan not to the convenience of the facility, but really to what the patient needs. Now that's going to be a real challenge because it requires more sophistication and maybe more expensive. But really we're treating patients, and the outcomes I think will be much better. So the other operational implications are that you're going to need to really look at documentation and credentialing, governance, have your own quality assurance program within your facilities, and then the technological things that we mentioned, the electronic medical records, and that's not an easy one because it's a big investment of time and money, and you don't want to make the wrong bet. But there's enough, I think, knowledge now that, it's not like there's so many people to look at for this kind of thing, but you want to make sure that it's interoperable, that it will talk to other systems. You want to make sure that from your medical record, you can draw the data you need for outcome studies. And outcome studies, there's different levels of doing that. You do the obvious readmission rate and AMA rates and sobriety and all. But then there's a lot more levels of sophistication with a good EMR and consultation or your own data analyst you can be doing. Telemedicine we've heard a lot about, and I've been involved with telemedicine quite a bit. I work with the American Telemedicine Association. And I would recommend that for those of you interested in doing that, it's not that complicated. First of all, the ATA, American Telemedicine Association, is a great resource. You go to their website, you'll find out all about state regulations, you find out what the best protocols are for direct-to-consumer, for behavioral, what some of the vendors are, licensing requirements. and then you're up and running. And it's not really that complicated, and it expands your ability to follow the patients longer term. Be careful about practicing in a state you're not licensed in, and it depends where the patient is located. You need to be licensed and have malpractice in that state. And then, of course, now you have to really worry about HIPAA even more, security, as well as all the rest. So the challenges are quite great. Again, compliance, we mentioned that. Relationships are really the key here, and that is, with the payers, with the medical community, and to become part of the community that you're practicing in, and training, as we mentioned before. So let's take a look now about just on the financial things here. This is important. Be prepared, as you well know, that the shift is away from residential to more outpatient treatment, lower levels of care. Again, individualized care. Some people need a longer period of residential, some people shorter. Not everybody needs to enter the system through residential. So these are the things to be aware of. And also, if you want increased revenue, you're going to have to demonstrate that you're providing value. And so that becomes very important. And probably you're going to have to increase your volume and decrease your margins. The days of 40% of revenue coming from urinalysis testing are over. The days of added network are becoming fewer and fewer. And also, it's probably time to say goodbye to 30-day cookie-cutter approach as we move to individualized treatment that's based on the patient's needs. So you have to document your outcomes, your pricing needs to be fair, and the main thing is, what are your relationships like? But there's a lot of opportunity, as I keep saying. This is the Wild West now. There's all kinds of new opportunities here. Fee-for-service, that's the first thing, FFS. That will probably remain, and you could go that way. But there's probably fewer and fewer people that will be able to pay out of pocket. And you're very vulnerable to recession if you go that route. Case rates. So that's a new way to discuss things with the payer. And that way, you're not bothered about utilization day to day, and you share your data and that you're doing the right thing and not underutilizing. Episode of care cost. We talked that it's a chronic illness, and you could then go to the payer and say, we're going to be responsible to this endpoint of a certain parameters, perhaps sobriety at a certain level, function at a certain level, a certain amount of time, certain amount of sessions, and you have a different payment arrangement. Shared risk, where you're both in it together, the payer and you are sharing the risk, where you benefit if you're able to treat more cost effectively. Pay for performance was mentioned as well. And the big bonanza sort of in the future, if we can figure out how to do it, is really to be able to be paid for all the savings that we can bring to the medical system. The example here would be, if, let's say, a patient with chronic obstructive lung disease medically costs, let's just say, $3,000 a year on average. If that person has a comorbid anxiety or depressive disorder, well, that cost goes from $3,000 a year to $6,000 a year. Well, now let's take that patient and analyze the cost, total medical cost spend. If that patient with anxiety or depression with COPD also has a substance abuse, now his total cost spend is $9,000. So if you can identify that patient's depression and substance abuse and treat it at the front end, there's a savings of $6,000. Well, shouldn't you split that with somebody? And because your efforts are valuable and bring a lot to the table. So there's new ways of thinking about all of this. So there's a lot to consider here, and just to understand, nobody has this down. There's no one formula, so your anxiety is shared by all, and there's no wrong answers necessarily, so you figure out who you are and what you want to be. So again, the to-do list to take home is document, 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 outcome, outcome, outcome. Don't commingle your patients in your program. Don't put partial patients in with your residential patients. That's not really program integrity. That's not what you're being paid for. Use best practice. Think about medical necessity to drive what you're doing. Reconsider your lab policies if they need to be. Look at your patient cost share policies to make sure that they're all straight and verifiable. Watch out for patient recruitment and advertising. Make sure that's according to standard. Engage with the patient. That's the key term here, patient engagement. Look at this as a chronic condition and what you can do. Consider care management. That may be a product that you can be reimbursed for at some point in the future. Innovation, innovation, innovation. Telemedicine, electronic medical record, long-term apps, and provide the continuum of care, and then you'll be in a good position. So looking ahead, the main theme here is to partner with the payer, be part of the community, and take your place at the medical table. So while it's a challenging time, it's an exciting time, and for those who rise to the challenge and try new things, it can be a very rewarding time. Thank you.
And I know that there's questions in the audience, and we have a mic, so this gentleman right here in the front.
This is for everybody on the panel. So the theme I've heard from the panel so far is you've talked about partnerships, and yes, this is a partnership. In the environment that we exist in which is primarily behavioral health out of network, we're hearing a lot of in-network going on. I've seen in other environments, Department of Justice and state contract, a lot better collaboration between payer and providers. Yes, we've sat down at the table today, but I'm looking for more meat in those collaborative discussions. So my question is really, the theme I'm hearing from payers is more transparency, more accountability for the delivery of service, the delivery of outcomes, etc. My question is, what have the payers in place in terms of strategies and processes, and what are they doing today to be equally transparent and accountable when it comes to the hardships that the providers are facing? And what are the payers doing to be accountable to paying us on time, to paying us within a percentage of what they bill? And it's particularly hard when it's out of network because you have a different series of algorithms. But my question is really, how do we improve that? So, you say, a number of you have said, we're open to partnerships, we're open to this. That sounds great. But the reality is, how do we get to the table with you, not just today, but in the future, in modifying existing plans and developing new plans where you can truly hear from us from the meat, the boots on the ground? It's incredibly difficult to get access to you and to help impact that change.
Okay. Well, thank you for that thoughtful question. There was a lot in there, but some of the themes that I heard are, how do providers and managed care organizations work together for greater transparency, particularly around out-of-network? But how do you create systems of the future so that more of that information and payment transparency exists so that both sides can do a better job?
Yeah, I'll take it first. So with Cigna, I hear you, right? So how do you trust us, and how do you trust the providers if we can't even pay your claims right today, right? So. So, there's a lot of work that goes into that. Obviously, we've been spending a lot of time over the last couple of years updating claim systems, trying to make them compliant with mental health parity and all those new regulations and everything else. And certainly the goal is to get claims paid quickly and paid correctly, and we want to do that. Nobody's trying to withhold money or not pay or any of those sorts of things. But we do, on our side, we need to continue to get better at that and take advantage of the new technologies and make sure that we're paying appropriately. If we have a contract with you, that we're following all of those rules and paying correctly. And then out of network, making sure we're following the appropriate standards that are out there for how do you reimburse out of network claims. once we do that, as we do that, hopefully we will earn back some of that trust that we want to have. And the rest of it is just having conversations. Some of it's starting here, right? So I've talked with several people here, either at the tables, in the round tables, or in the hallway. Conversations start that way, same way they start with lots of businesses. But you all, if you're in network, you have representatives that own your contract. Ask them if you can talk with some of the clinical leaders as well at the various payers. We are happy to get involved and engaged and talk with providers as well. So I think those are the ways to get involved. Our side owns making sure that we're following processes and paying claims and getting that part taken care of, and hopefully then we can get past those conversations so we can have them get to the meat of the conversation about where do we go next.
What are you doing to improve that? What is Cigna doing to improve paying?
How about the mic?
Yeah, I guess I need more detail. I don't know about what we're not paying providers. As far as I know, we're paying people. It may be delayed in times or something else. There may be a problem. But we're doing everything we can to make sure that appropriate claims get turned around and get paid. So if you have specific issues
Doug-
as a facility with claims that aren't getting paid, then you need to contact.
Doug, my name is Michael Walsh. I've done a lot in this field. I'm on the C4 board, first of all, so I want to thank you all for being here. A lot of people have a lot of questions. I mean, we could spend all day here doing this, and I hope that you will take the opportunity at some point, as the gentleman said, to have more conversations with us. I work right now for an out-of-network provider, but I've worked for private pay in this industry. I've run the National Association of Addiction Treatment Providers. I've been on the ASAM board. I used to be in insurance industry, so I get it. And in theory, I absolutely, and most of us in this room, if people didn't believe what you were saying on there, on the PowerPoints, they wouldn't be in this room, they'd be out there. So you're talking to the people in here, for the most part, who want to help people and make an honest day's living for an honest day's work. Have good outcomes, provide services. That's the theory of it. The practice of it and the reality of it, and I've worked 20 years in this industry on the ground, and only the last year I've worked on the insurance part of it. And I knew there'd be a learning curve. I've done it from NATAP, talking to providers, talking to the high-end programs, talking to the indigent programs about their struggles and how to treat patients and provide a service and get paid for it. The reality of it that I found out this year, being on the ground in it, is totally different. And I don't know whether people at your companies understand that we can sit in a room and talk about theory and talk about outcomes, but the reality of it, for instance, for a 20-year-old that doesn't have a GED, that's addicted to heroin, that's getting 30 days at an out-of-network program over and over again, and sometimes the company gets paid for it, to get out of treatment, to get clean and sober, to get job skills and parenting skills, because one of the things we talked about is the family program. Most good programs have unbelievable family services available. The reality is we can't get the families to return our phone calls. So these kids are going to never get to what we're talking about here. And that's a lot of talk. My question is, how do we do this tomorrow, the next day, the day after, to get all of you and your companies to understand what the people in this room are trying to provide to get to that, and how do we do it by giving an honest day's work and getting an honest day's paid? Because the divide is huge right now, and we're never going to get to that. What we'll get to is we'll get to Walmart. They won't do what you know clinically, because I've read your websites. And I've also been on the other side trying to get in network so we can get paid to do the services, but the networks are closed. And to be frank, the programs, for the most part, that I see, at least within 100 miles of me, don't provide the services, let alone that you talked about there, that are on your websites now. They don't provide those services, so that people aren't getting those products from you now, and we'd love to provide them for you. So the question is, how do we continue to do this today? How do we practically, not in theory, get to where we can provide our services, to provide good treatment, to help people, and get paid for it? Because that's what everyone in this room wants.
I mean, I think there's a lot in that, and absolutely, we want to get there with you, okay? you know, I'm trying to figure out where to start with all of that, because there was a lot there. But at the end of the day, a lot of what you were talking about is about out-of-network facilities. I will tell you, as insurance plans, as I mentioned, a lot of the effort is how do we work better with network to make stuff available. So if you're out of network and want to be in network, we want to talk to you about what are you providing, how can you do that, and how can you become a network provider. That's really where a lot of the focus is with healthcare today. People have out-of-network benefits, and they take advantage of that, and that's what they get today. But there's less attention being paid to how are we managing the out-of-network, because a lot of the focus is how do we get more people to be in the network? How do we increase the access? How do we do that? That's ultimately where healthcare in general is trying to head. Murray?
I just wanted to help Doug and give a counterpoint. I didn't want Cigna to get all the attention and Optum be left out of this. So, so there's a few things to add to that, and I think all that's true. But the question had a lot to do with what do we do now, and there's a few suggestions I would make from the sidelines here. One is through professional organizations, the American Psychiatric Association, American Psychological Association, ASAM, to be approaching payers in a collaborative way and sit down at the table together, because that is a lot of power. Then on the individual basis and what to do tomorrow, most of your facilities have access to the network managers in your district, so it's very important to develop a relationship with them. The more you get to know them, have them come visit, show them what you're best at. And it may at first take, it's like dating, you know, the first date may be a little cold, but then you develop a personal relationship and they know you and they can represent you to the network in general at that particular payer. And then somebody mentioned, I think Fatima, you might have mentioned that to join panels and advisory groups of the payers, and then you're sitting at the table and you feel their pain, you walk in their shoes, and you have a lot to add on an immediate level. So there's a range from the macro and organizational, and also here one night there was like the cause group got together, and there's two ways to go. You can yell and scream and go in front of the cameras and try to sue. Let me tell you, from the world of eating disorders, that we've been through all this in that world and it didn't work. But collaboration really works, because I think all the payers are similar and they want to hear from you, they want to do the right thing, they want to get the claims paid, and they want quality and outcomes. And neither of us can do that in a vacuum.
Hi, we've spoke a whole lot about cutting costs today and reducing the cost. I mean, underneath all of that, essentially, that's what's the message has been. And the reality of it is that Cigna, from 2010 to 2014, their stock was up 305%. In the last 2 years, the health insurance stocks are up 107% over the past 2 years alone. So obviously, we're being asked to cut costs and to make you more profitable. And that to me is not what's being presented here.
The focus on healthcare cost is really for all of us, right? So at the end of the day, none of us are going to be able to afford insurance if we don't control the cost of healthcare. Substance use disorders is a small piece of the pie, as we all know. I wish it was bigger. The pie's not getting bigger. So we have to figure out as a society what money we have gets spread around within healthcare, and how we are going to spend it, and the trend of it increasing has to go down. Absolutely, it's the responsibility. Well, I think that's why we want to create and get into partnerships so we can all grow together, right? This is not about putting anybody out of business, you or us, or our patients, or the employers who are buying their insurance today. Everybody needs to stay in the game if this is going to work. The system has to evolve, and we have to find ways to do this all more efficiently.
We've got like one more question. I'd like you to take a pen and a piece of paper and figure out the cost of staying at Motel 6 for a week, going to Golden Corral or Denny's for 3 meals a day, having 24-hour nursing available, seeing a doctor every week, complying, having an EHR system, governance, and everything else you put on there, and be in network and get paid $300 to $400 a day. Second, I'd like you to come in my office and see the utilization review where we've got 6 different definitions of medical necessity. Not one, none of them based on ASAM, which my doctor is ASAM board certified, but he can't figure it out. And finally, you want me to put someone whose brain is fried, have them 10 days of residential, and then send them out unsupervised in a residential facility, not residential, I shouldn't say that, a sober living home, unsupervised to do PHP and IOP? Really?
I mean, I don't even know where what the actual final question is there, but, you know, to the point of guidelines and what we're doing, there are, you know, we want standards as well, and we need national standards, right? I know Cigna's working with ASAM today. We're giving ASAM all of our claim data so they can look at it and use it to help create national standards. How are we measuring this? How are we defining what services need to be part of every residential program, every partial hospital program? We want to get there. There needs to be national standards. I agree with you. I think we're a lot closer from a medical necessity standpoint at the more acute level of care than maybe some others think. But we need to get there. We need to get better. I agree. And together and working through those groups like ASAM and others and the other advocacy groups, I think we can get there.
So, you know, that's an important point about the medical necessity criteria and all. And when I was before the APA, American Psychiatric Association, and they were in the early days of managed care, and I said to them, the only reason managed care exists in behavioral health is because our own APA never came up with guidelines, never established, you know, quality and outcomes, and never policed itself. So somebody wound up stepping in to the fray, and I'm afraid that's, you know, the same in substance abuse. And so that's the evolution of this. But really, I suggest everybody read the medical necessity treatment guidelines of all the big payers and line them up line by line, because we just went through this in a consultancy that I did, and they're incredibly similar. So it's not that confusing. They're not that disparate, and you know, some of them say 24/7 nursing, some of them not. Some 48 hours, some 24 hours for this or that, but there's really not that much of a difference. And I agree that ASAM, really the criteria should be used much more, and people should all be more familiar and do some of the judgments on authorization based on that.